Welcome to my first progress report. I'm Boglárka Fehér, and my topic is altered vaginal flora in pregnancy. I'm a medical doctor at the Department of Obstetrics and Gynecology at Semmelweis University. I believe that pregnant women will have better outcomes due to professional prenatal care, and my mission is to find new possibilities of screening and treatment of genital mycoplasmas in pregnancy. To complete this mission, I am currently working on two projects. The first one is about investigating the effect of genital mycoplasmas on adverse pregnancy outcomes, and my second one is about investigating the effect of different regimens used for bacterial vaginosis in pregnant women. I would like to perform them both through systematic reviews and meta-analysis. First, let me talk about my first project, investigating the effect of genital mycoplasmas on adverse pregnancy outcomes, which was started in this year in September. There are plenty of people affected by STIs worldwide. Each day, more than 1 million of them are acquired. This fact is eminently due to that they are commonly asymptomatic, so the patients are even not aware of the disease, therefore they can easily pass them to their partners. The so-called genital mycoplasmas can also spread by sexual activity. 4 of them can cause serious consequences, both in men and women. These are namely ureaplasma urinalyticum, ureaplasma parvum, mycoplasma genitalium, and mycoplasma hominis. Here you can see the prevalence is quite high, 80% for ureaplasmas and 10 to 20% for mycoplasmas. This is similar in pregnant and non-pregnant women. Unfortunately, recent guidelines currently have no suggestions on genital mycoplasmas except for mycoplasma genitalium. The reason of that is the controversial data found in the literature about pathogenicity. Nevertheless, there is plenty of adverse outcomes can be associated with them. In case of colonization, almost half of the pregnancies can end up preterm. Furthermore, the risk of spontaneous abortion, premature rupture of the membranes, low birth weight, and perinatal death can be unacceptably high. Although all these complications are very dreadful for pregnant women, early detection could be able to prevent them. So, my aim is to investigate interrelations between genital mycoplasmas and adverse pregnancy outcomes. To reach this aim, I chose this clinical question. Do genital mycoplasmas increase the risk of adverse pregnancy outcomes? The framework of the study is a PICO, and I'm going to investigate pregnant women. The exposure is genital mycoplasmas, the comparator is no genital mycoplasmas, and the outcome is adverse pregnancy outcomes. My hypothesis is that pregnant women with genital mycoplasmas have higher risk of adverse pregnancy outcomes. And by answering this question, I hope that screening and treatment of genital mycoplasmas during preconceptional period and pregnancy can reduce the risk of related outcomes. I've conducted a systematic search in 3 medical databases, and I had more than 10,000 findings with the search key below. I have several key articles which proves that my study is feasible, and most of these articles have a cohort study design. So, in the beginning, after the systematic search, I had 10,493 citations. After the duplicate removal, 7,417 remained. And I performed the title and abstract selection, and I had 2,118 full text to select. And at the end now, I have 300 eligible articles to analyze. Here you can see my first project progress. Currently, I'm at the stage of data extraction. Let me introduce my second project, investigating the effect of different regimens used for bacterial vaginosis in pregnant women. This was started in this year, October. Bacterial vaginosis is a shift from the relative abundance of lactobacilli to a microbial diversity, including anaerobe bacteria, like genital mycoplasmas. The prevalence of bacterial vaginosis is quite high. Almost half of the population could be affected. Bacterial vaginosis can be associated with adverse pregnancy outcomes also. The risk of preterm birth is the highest, but it can be related to premature rupture of the membranes, low birth weight, and even miscarriage and neonatal death. According to the guidelines, the traditionally used antibiotics to treat bacterial vaginosis are metronidazole and clindamycin. This is the same in pregnant and non-pregnant women. The alternatively used drugs can be dequalinium chloride, povidone iodine, and probiotics. Unfortunately, just a couple of guidelines mention alternative regimens, although they could have less side effects, and they could have better effect on vaginal flora by preserving the lactobacilli, so they could prevent relapse and improve maternal quality of life. The most conclusive studies about the efficacy are limited to non-pregnant population. Investigations in pregnant women examine only the effect on preterm birth, and alternative regimens are not involved. So my aim is to investigate the effectiveness and safety of the treatment of bacterial vaginosis in pregnant population. I chose this clinical question: which regimen is the most effective to treat bacterial vaginosis during pregnancy? The population is pregnant women with bacterial vaginosis. The intervention and the comparator is different regimens. The mechanism is the effect on vaginal flora. My primary outcome is the resolution of bacterial vaginosis, and the secondary outcomes are adverse pregnancy outcomes, the symptoms, and the relapse. The hypothesis is that alternative regimens have the same or higher effectiveness and safety in bacterial vaginosis treatment compared to the traditional antibiotics. And the implication would be that treatment of bacterial vaginosis in pregnancy can reduce the risk of adverse outcomes and improve maternal quality of life. Here you can see my preliminary search key. It contains several domains, including the population, and some kinds of interventions of our interest. After the preliminary research, I had more than 3,000 findings. I found some key articles with similar PICOs, so this topic is promising, and I'm going to start the preliminary data extraction. To summarize, here you can see my future plans. I am going to finish both of my projects until next autumn. Let me finish my presentation with a thought-provoking quotation by Gandhi: "Be the change that you wish to see in the world." Thank you for your attention.
First of all, thank you for your presentation. It was very nice. And I would like to learn which adverse pregnancy outcomes would you like to focus on your second project?
Unfortunately, I could find just one study about the alternative regimens, which includes pregnancy outcomes, not just the efficacy. This investigated the perinatal asphyxia and hypoxia and intrauterine growth restriction. But if I could find enough data, I would assess also the preterm birth and pre-labor rupture of the membranes and perinatal death, as in my first project.
Thank you so much.
Thank you for your question.
Thank you, great presentation. I am a pediatrician, so I'm very enlightened with these topics. About your second topic, you choose a hard outcome for the first one, the resolution of bacterial vaginosis, but you narrow your population to the pregnant woman. I understand what you are looking for, but can you answer me why do you? So when you choose your first outcome regarding your population, so why is it? Thank you.
Actually, there are several meta-analyses which examine adverse pregnancy outcomes and the effect of metronidazole and clindamycin on pregnancy. That's why I choose this one as a primary outcome. Regarding the population, my topic is pregnancy, so that's why I choose pregnant women. But it's worth it to investigate alternative regimen in the general population also. There are some ongoing studies which are investigating this, and not just these alternative regimens, but also a second-line treatment with the probiotics. So I found some data about that.
I was wondering, what are the cause of the conflicts in the pathogenicity of mycoplasmas?
It's a good question. Actually, I showed that the prevalence is very, very high, so it could be even 80% in case of urulplasmas. And not in every case complications will occur, and this proves that they can be a part of the normal vaginal flora also. But the vaginal flora is very, very complex, and the pathogenicity regarding, so based on the studies, can depend on the microbial load, and it can depend on the amount of lactobacilli, the protecting lactobacilli, and it can depend on the co-infection with other STIs or opportunistic bacteria. So there are several investigations, ongoing investigations, which are trying to answer this question. Thank you.
It's a very exciting topic for me, especially the first one, and I have a question regarding your first topic. The treatment of mycoplasma is very challenging due to the rapidly increasing antibiotic resistance, and newer guidelines don't even recommend azithromycin empirically. Instead, they recommend doxycycline and moxifloxacin addition, but you can't use this agent during pregnancy. So if your meta-analysis provides data supporting adverse events associated with mycoplasma, what agent would you choose? And have you considered including in your study maybe the connection between the antimicrobial agents and adverse events on pregnancy, and comparing it the adverse events on pregnancy of mycoplasma?
Actually, the problem is I found just one guideline which contained data about the treatment of mycoplasmas in pregnancy, and it included only just mycoplasma genitalium, because so as I mentioned, there are controversies about even the pathogenicity. And I also would like to find studies, RCTs, about the treatment of genital mycoplasmas, but there are just really some of them. So further investigations should focus on that, because as you said, there is a high so the resistance is very, very high regarding azithromycin, which would be the first line treatment for that, and including this regarding this guideline, it recommends azithromycin for pregnancy, but that's the only one. There are studies which choose erythromycin, which would be safe, but there's a lack of these studies. So thank you for your question.
Thank you.
So in your second topic, you discussed the treatment of bacterial vaginosis, but are you going to investigate the treatment of mycoplasmas as well?
Yes, thank you. I would like to. That would be my second topic. But when I checked the articles about the treatment of genital mycoplasmas, I could find just some of them, and they were performed in the 1990s. And there is one existing meta-analysis in this topic, and even just one of these articles could be contained in this meta-analysis because of the lack of the exact data in them. So I couldn't, but if there will be recent ongoing studies finished, I really would like to. Thank you.
Thank you.
There is disagreement among clinicians about the use of metronidazole and clindamycin in the first trimester. Do you have any data about this?
Yes, thank you. I found a comprehensive study about the safety of these two antibiotics. Mostly we focused on the alternative regimens, but according to this study, both are safe even in the first trimester. They won't cause any congenital anomalies. Thank you.
Thank you.